Preface of the Prospective Mother. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Jeanette Seelig. The Prospective Mother, A Handbook for Women During Pregnancy, by J. Morris Slemons, Associate Professor of Obstetrics, the Johns Hopkins University. Preface. This book, written for women who have no special knowledge of medicine, aims to answer the questions which occur to them in the course of pregnancy. Directions for safeguarding their health have been given in detail, and emphasis has been placed upon such measures as may serve to prevent serious complications. Treatment of such conditions has not been discussed, as it can be judiciously carried out only by a physician who has the opportunity to observe and study the individual patient. Furthermore, if there is to be notable improvement in the management of cases of childbirth, the appearance of untoward symptoms should not be awaited before consulting a physician. On the contrary, prospective mothers must be taught that they should be under competent medical supervision throughout pregnancy. At present, intelligent women demand some knowledge of the anatomical and physiological changes incident to the development of the embryo and the birth of the child. These subjects do not readily lend themselves to popular description, but I have told the story as simply as possible, following in a general way the textbook of my teacher and friend, Professor J. Whitridge Williams. Indeed, my main purpose has been to reproduce his book in words of one syllable. The use of a number of technical words has been unavoidable, and though their meaning has been given in the context, it has not been feasible to repeat the definition every time an unfamiliar term was used. On that account, a glossary has been provided. It is with pleasure that I avail myself of this opportunity to acknowledge the cheerfully given assistance of many friends. In particular, I wish to thank Dr. Henry M. Hurd, until recently superintendent of the Johns Hopkins Hospital, for his interest and advice. I am also under deep obligation to my friend John C. French, of the English Department of the Johns Hopkins University, for helpful criticism of the manuscript, and to my colleagues, Drs. Rupert Norton and Thomas R. Boggs, for valuable assistance. To many others, doctors, nurses, and patients, I am indebted for numerous suggestions, which have been made either consciously or unconsciously. End of preface. Recording by Jeanette Seelig.
Chapter 10, Part 2 of The Prospective Mother. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. The Prospective Mother by J. Morris Slemons. Chapter 10, Part 2 The Birth of the Child. The Effect of Labor upon the Child. Unless the experience of countless generations had taught us otherwise, we should fear the child would be injured by its passage through the birth canal. Immediately after the birth, evidence of the journey is seldom wanting, but it quickly disappears. The unusual size of the infant's brain requires the head to be large, and bestows upon it a contour which differs from that of the mother's pelvic cavity. Since the bones of the pelvis are rigid, while those of the fetal skull are malleable, the head is molded as it descends into the pelvic cavity, so that its passage may be made the easier. As the result of this process of accommodation, the skull becomes relatively longer from crown to chin than in adults. Within a few weeks, however, the modification vanishes. If an infant is born with the buttocks first, the head does not linger in the birth canal, a fact which in such cases explains the pleasing shape of the skull, which emerges with the contour determined by fetal growth. Whenever a soft swelling appears over that portion of the scalp which was foremost during the birth, the curiosity of the family is aroused, but the swelling is harmless and subsides quickly. It originates from the same reason that a finger swells if too tight a ring is worn, which, as everyone knows, is because of the interference with the circulation. Just as the swelling of the finger disappears when the constriction is removed, so the swelling of the scalp subsides shortly after the child is born. Usually no trace of it can be found the next day, but even when more persistent, it will always vanish after a short time. For the child, the most notable result of labor relates to the revolutionary changes in its mode of existence. Up to the time of birth, the fetus received nourishment by way of the placenta, but after separation from the mother, another source of food must be found. The health of the tissues, perpetually in need of oxygen, requires that the lungs act very promptly. Contact with the air, which is cooler than the previous environment of the child, irritates the nerve endings in the skin. In response to the sensation thus produced, breathing is established automatically. Whenever the temperature stimulus proves insufficient, physicians employ a stronger one, spanking the child until it cries lustily. Crying not only expands the lungs, but also has a favorable influence upon needful alterations in the fetal circulation. The lungs, since they must from this time on provide oxygen for the infant, need to receive more blood than formerly. The vessels leading toward them must be widely opened, and structures which previously diverted the bloodstream to the navel must be closed. The intricate shifting of forces which produces the change cannot be understood without a knowledge of anatomy. It will suffice for us to know that the blood is drawn into the vessels of the lungs with each inspiration. Other changes also occur. On account of some of these, namely, certain alterations in the blood current through the heart, physicians once taught that newly born infants should always be laid upon the right side. Except in very unusual cases, that precaution is now regarded as unnecessary. Of all the elements essential to nutrition, oxygen is the only one required immediately after birth, as the child enters the world well stocked with all the others. Babies are not born hungry, as many people seem to think; neither is their crying a proof of it, for, as we have observed, they have other very good reasons for crying. Nor is their readiness to suck anything that comes in contact with the mouth, for they will behave in the same way while they are receiving an abundance of nourishment through the umbilical cord. Many hours pass before a newly born infant can possibly need food. Indeed, it could survive a week or longer without taking anything by mouth except water. The ability to suckle at birth merely indicates that the infant is prepared to utilize the mechanism which nature will now employ to sustain it. After the umbilical cord has been severed, the blood vessels within it can serve no further purpose. Consequently, the remnant of this structure attached to the child's abdomen begins to shrivel. Formerly the care of the stump was considered a trivial matter. When cleanliness was neglected, decomposition caused more rapid separation than takes place under the treatment which it now receives. No annoyance should be felt because the cord hangs on a long time. Indeed, such an experience means it has been given exceptionally good care. Separation rarely occurs before the end of a week. It may be deferred for 2 weeks or even longer, if the stump has been kept perfectly clean. After the shriveled cord drops off, the skin around the navel contracts, leaving a small raw area which discharges a yellow fluid for 2 or 3 days before the healing is complete. Meddling. In selecting a physician, the patient will almost certainly have been guided by her confidence in his ability. It may seem strange, therefore, to insist that he be allowed to conduct the delivery as he thinks best. Nevertheless, suggestions from outsiders are so common, especially if the labor be at all prolonged, that it seems appropriate to warn patients to pay no attention to such advice. In the heat of excitement, well-meaning relatives are sometimes inclined to interfere, and women who are not members of the family occasionally wish to discuss their experiences, irrelevant as they may be. The patient's intimate friends, quite naturally, have the keenest personal interest in the event, an interest that of itself disqualifies them from reasoning calmly at the time. Their influence may be positively harmful if they persuade the physician to undertake procedures which his judgment convinces him are inadvisable. Should he turn a deaf ear, they will think him lacking in sympathy, but should he adopt their suggestions, he would assume the full responsibility, and would perhaps be censured later by the very persons whom he sought to please. There can be no question of the proper course for him to pursue. Any influence which such entreaties may have will always be in the direction of too early interference, which is fraught with danger to mother and child alike. The master word is patience, and it applies alike to the mother herself, to the doctor, and to her friends. Almost always the whole duty of the doctor consists in watching the progress of labor, so that he may be ready to render assistance should it be needed. Until the second stage begins, there is no real necessity for him to remain in the room. Indeed, it is better for him not to do so after he has made sure that satisfactory conditions prevail, for his judgment will be less biased if the patient is not continuously under his observation. Justifiable intervention. It is quite true that in the progress of the birth difficulties now and then arise. yet they are far less common than rumor would lead us to believe. The unusual always attracts attention, often receiving greater emphasis than it merits. The particulars of confinement provide no exception to this rule. A delivery which requires artificial aid will be talked about, while hundreds that terminate naturally pass without comment. In this way the public gets an exaggerated notion of the frequency of difficult labors. Moreover, the nature of the trouble is usually distorted, for reports of medical events are apt to be incorrect, and errors multiply with each rehearsal. Obstetrical patients who wish, so far as possible, to escape the depressing influence of such inaccurate reports will be most likely to succeed if they follow the advice to select a physician at the beginning of pregnancy. When this is done, the physician will have opportunity to explain or discredit alarming rumors, a task which it is usually necessary for him to perform, for there are always some persons who feel that a prospective mother should listen to everything that they have heard of childbirth. The most frequent cause for intervention during labor is insufficiency of the muscular contractions to overcome the resistance of the birth canal. Unusual resistance of this kind explains the longer labors of women who have passed middle life before becoming pregnant. They may need to exercise more patience than younger women, though they have no greater reason to apprehend serious difficulties. Whenever rigidity of the muscles adjacent to the birth canal arrests delivery, the physician may employ the obstetrical forceps, which have been in use since the 17th century. Although it is widely known that physicians sometimes terminate labor in this way, the public estimate of the merits and of the limitations of the instrument is so inexact that the truth about it should be understood. Obstetrical forceps were devised by one of the Chamberlains, a family of French Huguenots who fled to England in 1569. The invention was long kept a secret, therefore its dates cannot be fixed, nor even the inventor clearly identified, though everyone agrees that he was a member of this family. Clearly, the instrument had been in use for some generations prior to Hugh Chamberlain, who translated from French into English the foremost obstetrical textbook of his time. The book, published in 1672, does not contain a description of the forceps, but in his preface Hugh Chamberlain refers to delay in delivery, saying, "My father, my brothers, and myself, though no one else in Europe, as I know, have, by God's blessing and our own industry, attained to and long practised a way to deliver women without prejudice to them or their infants in this case." It is not questioned that the forceps was the secret that his ancestors and he himself employed so long and so profitably. About a century ago, what are probably the original models of the instrument were discovered in a country home of Essex, which once belonged to the Chamberlains. There they had been hidden in a trunk in the garret. The box in which they were concealed contained 4 pairs of forceps, representing different stages in their development, besides other instruments and a number of letters which established their ownership. After an unsuccessful attempt to sell the family secret in Paris, Hugh Chamberlain found a purchaser in Amsterdam. The privilege of using it in Holland was then granted physicians for a monetary consideration, and that practice continued until 2 philanthropists purchased the secret to make it public. It was ultimately learned, however, that the sale was a swindle, for the device which the purchasers obtained consisted of only half the genuine instrument. The real secret was revealed by a son of Hugh Chamberlain, who bore the same name as his father. But probably the first accurate printed description of the forceps was made by Samuel Chapman in his Treatise on Obstetrics, which appeared in 1733. Subsequently they came into general use, and with many modifications remain the most important instrument in the obstetrician's equipment. There can be no exaggeration in the claim that the instrument has done more to save human life than any other surgical appliance. The obstetrical forceps have been of such great service in diminishing the number of stillborn infants that they were once called the child's instrument. The need of its employment in behalf of the child may be determined by careful observation of the fetal heart sounds, which are heard over the mother's abdomen, and by means of which one may learn the condition of the child. Signs of danger are extremely uncommon so long as dilatation of the womb is not complete, for any strain which labor may impose upon the child will usually occur during its passage through the pelvis. Most often, therefore, the head has reached the outermost part of the birth canal before extraction becomes advisable. The forceps are used also on behalf of the mother, if the continuation of labor seems likely to throw undue stress upon her. On this account the physician frequently resorts to them if his patient is suffering from pneumonia, typhoid fever, or any acute illness at the time of labor. Other maternal indications for their use include various chronic derangements, well exemplified by certain diseases of the heart. Furthermore, even when there are no pre-existing complications, forceps are employed on account of exhaustion or other conditions which may develop during the course of labor. It must be clearly understood, however, that the physician alone can determine when intervention is justified, as well as what operative procedure is most appropriate. For even though good reasons for terminating labor exist, forceps cannot be properly used unless nature has already fulfilled very definite requirements. By no chance can the patient, much less her friends, decide this matter. And besides, none but a trained observer can detect the symptoms which clearly indicate nature's incompetence to effect delivery. Disregard of these truths by the family, with consequent urging that something be done, must be held partly responsible for the reckless use of this instrument. It will be a step in the right direction, therefore, when the laity comes to understand that the value of the instrument generally pertains to the welfare of the child, and that in any event its use will be harmful if employed before the womb has been completely dilated. Although forceps can be employed only in cases of head presentation, intervention may be warranted when some part of the fetus other than the head will be born first. 2 or 3 times in every 100 patients we meet with breech presentations, that is, cases in which the buttocks precedes. After their expulsion, the body, the arms, and the head follow. Breech presentations occur more frequently among women delivered prematurely, as might be expected, since an examination 8 to 10 weeks before the calculated date reveals a larger percentage of breech presentations than a similar examination about the normal end of pregnancy. In explanation of these results, we accept the view that the size of the fetus at the earlier date does not require nicety of adaptation to the cavity of the womb, whereas at term, unless the child is small, the best accommodation is secured when the head lies downward. Most breech cases are delivered spontaneously; if not, the outlook for the mother is no less favorable on that account. Assistance, when undertaken, is usually prompted in the interest of the child, which will be seized by the legs and extracted if there are indications to terminate labor. Purely as a precautionary measure, a second physician will often be called about the time the stage of expulsion begins. Foresight of this kind must give the patient confidence rather than alarm her. Indeed, should operative intervention of any kind become necessary in the practice of obstetrics, the inclination of the doctor to call an assistant must be regarded as evidence of superior judgment. Management of birth without a doctor. A prospective mother should not be left alone during the 4 weeks prior to the expected date of delivery, for it is important that during this period aid may be quickly summoned in the event of an emergency. However, if the confinement be the first, ample warning of delivery will always be given. Even in a later confinement, several hours will probably elapse between the preliminary signs and the birth itself. It is extremely rare to have labor progress so rapidly that the child is born before the doctor arrives. Under such circumstances, if the nurse be present, she will be master of the situation. Whenever she has been unable to reach the patient, some one near by should be called to render what assistance may be needed. A labor which advances so rapidly that skilled assistance cannot be procured is proof in itself that everything is going in an ideal manner, and that interference is not necessary. Although the doctor may not arrive until after the child is born, he frequently renders valuable service in expelling the placenta or in sewing up lacerations. No one should presume, then, that there is never need for a physician after the second stage is over. If the suggestions made in the preceding chapter are heeded, immediately after labor begins the room will be set in order, and the bed will be properly protected. The patient will take a tub bath, and will put on a freshly laundered nightgown. The sterilized dressings are then placed where they can be easily reached, but are not opened until needed. Antiseptic tablets have been procured, and following the directions on the bottle, it will be simple to make up a solution of bichloride of mercury of a strength of 1 to 1000. After the contractions become strong and return at intervals of 5 minutes, or if the waters have broken, the patient should go to bed. The knees should be drawn up and spread apart, but bearing down with the pains should not begin until the inclination is irresistible, since this forbearance will make the delivery slower, and thus afford protection against lacerations which physicians ordinarily seek to prevent by the use of chloroform. In the absence of a doctor, it is never permissible to administer this or any other anesthetic. As long as a physician familiar with its action gives the chloroform, untoward results need not be feared in obstetrical cases, but the risk would be too great to allow any one to give it who was unacquainted with the early signs of an overdose. Again, fear of accident should prevent patients from using the closet when labor is progressing rapidly, for an inclination to empty the bladder or the rectum often signifies that birth is about to take place. Even though this is true, if there is need, patients may try to use the bedpan. About the time when the patient goes to bed, the attendant prepares to render such assistance as may be required. First, she should scrub her hands thoroughly with soap and water, and subsequently soak them in the bichlorid solution for 5 minutes, or longer if there be no need for haste. A large delivery pad is then placed under the patient, the leggins put on, and from this moment the outlet of the birth canal should be exposed to view. After the scalp of the child comes into sight, the attendant is not to leave the bedside, though she must keep hands off until the head has been completely expelled. A pause occurs between the birth of the head and of the rest of the body. It is usually safe to await further expulsive contractions, but should the child's face turn a dusky blue, which indicates that it needs to breathe, the patient is to be advised to strain vigorously and to make firm pressure over the womb with both her hands. At the same time, the attendant must pull the child downward, having seized its chin with one hand and the back of its head with the other. The straining of the mother, combined with traction by the attendant, will be certain to effect delivery quickly. As soon as the child is born, it should take a breath and begin to cry. If it does not cry of its own accord, it can usually be made to do so by holding it up by the feet and slapping it on the back several times. Subsequently, the child is placed between the patient's legs in such a way as to prevent stretching of the cord. Usually, the nurse will leave it in this position and turn her attention to the mother. After the birth of the child, it is easy to feel through the mother's abdominal wall, which has now become lax and flabby, the organs which lie beneath it. The top of the womb, once just below the edge of the ribs, may now be found about the level of the uppermost part of the hip bones, a position which it keeps until detachment of the afterbirth begins. As the afterbirth peels off, the firmly contracted womb gradually rises in the abdominal cavity, and by the time when the separation has been completed, reaches the region of the navel. While these changes, which naturally require from 10 to 30 minutes, and occasionally longer, are taking place, the attendant must wait patiently. Attempts to hurry the separation of the placenta are never wise, for they may lead to excessive bleeding. No effort should be made to bring away the afterbirth by pulling upon the cord. It is equally unwise for inexperienced persons to press upon the womb in the hope of pushing out the placenta. To encourage the mother to strain, just as she did in assisting the birth of the child, would always be a safer plan. And if that is ineffective, further delay is necessary. In several instances, a natural separation of the placenta has repaid me for waiting as long as 2 hours. Prolonged delay may be annoying, yet provided that the doctor arrives within a reasonable time, it can scarcely lead to anything more serious than annoyance. Rather than authorize frantic efforts to remove the afterbirth, I should much prefer to have a patient of my own call another doctor. If the afterbirth comes away of its own accord, as will generally happen when due patience has been exercised, it may be severed from the child and put aside for the inspection of the doctor, for he should learn by examining it whether everything has come away properly. The cord must be securely tied in 2 places with the sterilized bobbin mentioned in the list of articles for confinement. One ligature is applied about 2 inches from the child's abdomen, the other an inch nearer the placenta. The cord is then cut between them with a pair of sterile scissors. Anyone fearful of injuring the infant may prevent accident by spreading a diaper under the part of the cord to be severed. This precaution also protects the bed from soiling, for there will be a single spurt of blood the instant the cord is cut. So long as the child is in good condition, there is no urgent need of this operation. If the child is breathing satisfactorily, it may generally be deferred until the doctor arrives. When this course is chosen, the attendant will wrap the infant in a warm blanket, place it along with the afterbirth in a safe spot, and subsequently devote herself to making the mother comfortable. The vulva and neighboring parts are bathed with a 1 to 1000 bichlorid solution. Soiled dressings are removed, the gown changed, and if necessary clean sheets put on the bed. A sterile sanitary pad is placed over the vulva and a fresh one substituted as often as necessary, but none of the pads should be destroyed. All the dressings must be saved so that the doctor may see how much blood has been lost. As we have learned, bleeding regularly occurs while the placenta is separating, and thereafter. Excessive bleeding will rarely follow a normal delivery, if the attendant has heeded the precaution to leave everything to nature. If ever the loss of blood should become alarming before the doctor arrives, it is advisable to raise the foot of the bed, to keep the patient quietly on her back, to grasp the womb through the abdominal wall, and to massage it constantly until the nearest physician can be gotten. Of these directions, the most important is that which relates to the management of the womb, for in cases in which labor has been normal, in other respects, the relaxation of its muscle is most often responsible for flooding. What to do in this event must therefore be made plain. First, the patient should try to empty her bladder, and if she cannot, pressure made above the organ will usually expel the urine. The attendant will then take her seat on the edge of the bed, facing the patient's feet, and will locate the womb. When there is flooding, one may expect to recognize the womb as a large, rather soft mass lying in the midline of the abdomen with its upper margin somewhat above the navel. With one hand, or with both if necessary, the mass is grasped in such a way that the fingers cover the top of it and pass backward toward the spinal column. The thumb remains in contact with the front of the organ. The womb is stroked and squeezed much as one kneads dough, and for this reason the procedure is technically called kneading. Such manipulations cause the muscle fibers to contract firmly, and in consequence the blood vessels are tightly closed and bleeding ceases. Similarly, cold applications to the abdominal wall tend to provoke uterine contractions. Placing over the womb an ice cap or towels wrung out of cold water and doubled several times often have a beneficial influence when there is a tendency toward relaxation. Some physicians also recommend that the child be placed at the breast, since suckling is known to cause uterine contractions. There are other measures which are occasionally employed, but they should be used only by physicians, for in the hands of an inexperienced person they may do more harm than good. Very often a slight chill follows labor. It has a nervous origin and need never give uneasiness. A drink of warm milk, hot water bags to the feet, and extra blankets will be sure to make the mother comfortable. On the other hand, excitement of any kind aggravates this condition. In general, recently delivered patients must be kept quiet no matter how well they feel. A few hours of sleep, or at least of repose, are justified by the fatigue incident to labor, and nothing should be permitted to interfere with it. Methods of reviving the child. Complications which interfere with the child's vitality rarely occur when labor proceeds so rapidly that there is not time to get a doctor. Nevertheless, a description of childbirth would be incomplete without reference to the measures intended to revive asphyxiated infants. Such measures aim, first of all, to make the infant breathe for itself, and if breathing does not begin promptly, we resort to artificial respiration. Mucus in the mouth or in the lower air passages hinders the entrance of air into the lungs. Consequently, it is the duty of the attendant to remove this mucus by means of gauze or some light fabric wrapped about a finger and passed backward over the tongue. In most cases, nothing else will be necessary, but if breathing is not immediately established, the attendant may stroke its face and chest with her hand, which has been previously held in cold water for a moment, or she may dash a handful of cold water upon its body. With very rare exceptions, these procedures make the child cry. One must always be alert to see the very first attempt at breathing, for unduly prolonged manipulations may defeat their own object. The natural inclination always is to do too much rather than not enough. In some instances, however, the measures thus far indicated will not prove successful, and if not, the cord must be tied and cut through, for subsequent treatment cannot be conveniently carried out while the child remains attached to the placenta. As soon as the cord is severed, the child is placed in a tub of warm water, about the normal temperature of the body, and is moved about in the bath for a few moments, the attendant watching closely all the while, for the breathing is often very superficial. Should signs of beginning respiration not appear, the attendant should grasp the child by the shoulders, dip it up to the neck in a basin of cold water, and quickly return it to the warm tub. This operation may be repeated 5 or 6 times. Generally, the instant the child touches the cold water, it draws up its feet, opens its eyes, and cries. One must take care that the plunge lasts but a moment. If the child becomes chilled, efforts to revive it will likely be unsuccessful. Indeed, the necessity for keeping it warm must be constantly borne in mind. With the very exceptional cases in which hot and cold tubs are ineffective, the following method becomes valuable. Wrap the child in a blanket and lay it face downward upon a table or chair, allowing the head to hang over the edge. Roll the body on one side or a little beyond, then slowly roll it back upon its face and onward to the other side. This maneuver is repeated 14 times to the minute, but not more frequently. When properly performed, it secures a flow of air to and from the lungs with the same rapidity as in the normal respiration of an infant. Efforts to revive the child must not be quickly given up, as a successful outcome occasionally requires half an hour of work or even longer. One method after another should be tried in the order which I have indicated. A physician always perseveres so long as the heart sounds can be heard, but since an inexperienced person might be unable to decide upon this point, the most reliable course for the layman is to persist in the resuscitation until the physician arrives. End of Chapter 10, Part 2.
Chapter 11 of the Prospective Mother. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Pamela Krantz. The Prospective Mother by J. Morris Slemons. Chapter 11. The Lying-in Period. The changes in the uterus, the lochia, the return of menstruation, other restorative changes, the loss in weight, the abdominal wall, the pelvic floor. The care of the patient, the elimination of waste material, cleanliness, the diet, the environment, the time for getting up. The final examination. A generation ago, physicians were accustomed to see their obstetrical patients only at the time of labor. No preliminary examination was thought necessary, and after the delivery visits were not made unless the family became alarmed and requested them. When thus asked to come back, the physician sometimes found that an infection had developed. Occasionally the breasts were giving trouble, or some other difficulty in the care of the mother or of the infant was baffling the nurse. It is now recognized that the medical attendant should not wait for the appearance of untoward symptoms. Although the strict observance of the various precautions which I have already emphasized should lead, and usually do lead, to an uneventful convalescence, it is none the less true that the danger of infection and of other immediate complication has not passed until several weeks after delivery. For this reason, and also because skillful guidance of the mother at this time will prevent unwelcome sequels in the later years of life, physicians now extend their watchfulness beyond the hour of birth. The number of visits ordinarily required is not large. In each case, to be sure, the circumstances will determine the number, but as a rule 10 visits, if properly distributed, will be sufficient. During the month succeeding delivery, these visits should be made in about this order: a daily visit for the first 5 days, subsequently 1 upon the 7th, the 10th, the 14th, the 21st, and the 28th day. At the conclusion of labor there begins a series of changes which are the reverse of those incident to pregnancy, and which restore the body to its original condition. 6 weeks are generally required for these alterations. They should leave the mother in perfect health, but traces of pregnancy are not entirely effaced. Even in the absence of outward evidence, if a woman has ever given birth to a child, a thorough internal examination will disclose the fact. The initial steps in these restorative processes are taken most promptly and effectively when patients remain in bed. The traditional custom of doing so has given to the first few weeks following delivery the popular name, the lying-in period. To these weeks physicians usually apply the technical term puerperium, the child's period, a designation which brings to mind the secretion of milk, which, though not a retrogressive change, is nevertheless one of the most distinctive results of childbirth. Radical as the bodily changes in progress at this time are, the lying-in period is not a period of illness, but there is perhaps no other time in a woman's life when she may cross the boundary between sickness and health so easily, for here nature tolerates no trifling. Not infrequently, puerperal patients who are feeling well attempt too much, and suffer a more or less serious setback. It is an all-important duty of the obstetrician, therefore, to restrain them from harmful activity. In my experience, patients yield to restraint most readily and secure the best results, if I explain to them the anatomical facts which should guide the management of the lying-in period. The changes in the uterus. Since, of all the organs, the uterus undergoes during pregnancy the most extensive development, it also holds the place of prominence during the lying-in period. Immediately after delivery the womb weighs 2 pounds and measures some 8 inches in height, 5 in breadth, and 4 in thickness. In the course of a few days it begins to dwindle in size, gradually sinking in the abdomen until it lies entirely within the pelvic cavity. Toward the end of 5 or 6 weeks it resumes the position occupied before conception, regains approximately its original dimensions, and weighs 2 ounces. We speak of the process which leads to these results as the involution of the uterus. Since a great deal depends upon the rapidity with which involution progresses, we must understand just what it is and how it may be influenced. The muscle of the womb, to which this property of involution belongs, is an aggregation of thousands of individual fibers. In response to excellent nutrition during pregnancy, these fibers have grown thick and strong, in order that they may furnish the power needed at the time of labor. When this purpose has been fulfilled, each fiber becomes smaller and gradually passes into a resting stage, the better to preserve its vigor. It is the shriveling of the individual fibers, therefore, which accounts for the total reduction in the size of the womb. Although the source of the stimulus which causes the muscle fibers to atrophy is not so clear as we should like it, we are acquainted with certain influences to which involution is susceptible. Of these none merit so much attention as the influence of the breasts. The intimate relation between the breasts and the uterus manifests itself in such a variety of ways and with such force that no one doubts its existence. Thus, if a nursing mother becomes pregnant, her infant is usually deprived of sufficient nourishment or suffers some digestive disturbance. If not, and the mother, ignorant of her condition, continues with the breast feeding, she may jeopardize the newly begun pregnancy. Very likely she will be warned of the fact by the signs of threatened miscarriage. More frequently, but in quite the same way, we find that nursing causes uterine contractions in the early part of the lying-in period, when they are called after pains. Women who experience them tell us they are more severe while the infant nurses, and they also say that the discomfort disappears after several days, a fact which indicates that involution has made notable headway. The physician is not dependent on such evidence, however, for a simple examination reveals at any time how far involution has progressed. By this means we have learned that nursing facilitates the involution process. On the other hand, it is found to be true, as we should naturally expect, that women who decline to suckle the infant recover from childbirth somewhat less rapidly than those who follow nature's plan. In this fact, therefore, is found a selfish motive, yet a very good one, which should impel mothers to perform this exceedingly important duty. Aside from the change in the mass of the uterus, notable results of involution relate to its mouth and to its ligaments, for these structures are also chiefly muscle. The mouth of the womb, lately stretched to permit the exit of the child, gapes widely for a time, but ultimately its lips are drawn together, the tissues which compose them stiffen, and the canal which they enclose is narrowed to almost microscopical dimensions. When involution is complete, the uterus has so far regained its virginal character that no trace of childbirth remains other than a few small fissures in the margin of its mouth. It is the office of the ligaments to hold the uterus in proper position. In consequence of pregnancy they have been stretched, and as we might anticipate, after the contents of the womb are expelled, the ligaments hang loosely from its sides, very much as sails hang when a breeze dies down. Immediately after delivery, therefore, the ligaments give the womb little or no support. Eventually they shorten and tighten, readily accommodating themselves to the existing conditions. Until the accommodation is perfected, it is especially desirable to permit no pressure which might push the womb backward. It is for this reason that many obstetricians object to the time-honored custom of applying a tight bandage about the abdomen at the conclusion of labor. For though bandaging is not always harmful, it has a distinct tendency to misplace the womb. A friend who has served as an assistant in one clinic where patients were bandaged regularly and in another where they were not, tells me that displacements of the womb were much more common among women treated by the former method. While the process of involution is altering the shape and size of the womb, other forces are at work within the organ to provide its cavity with a new mucous membrane. In character and in extent, the inner surface of the womb, left raw and bleeding at the conclusion of labor, is comparable to the wound which would result if some accident removed the skin from the palms of both hands. No one would question the wisdom of guarding such an injury to the hands, but cleanliness is even more necessary to the prompt and healthful restoration of the uterine mucous membrane. However, the wound within the uterus is so far from the surface of the body that it need not be directly covered with a surgical dressing. Sterile pads are kept over the vulva to exclude contaminating material until the healing is completed. Since bleeding ceases after that point is reached, we have no difficulty in knowing when the mucous membrane has been restored. The lochia. The vaginal discharge which regularly follows the termination of pregnancy gets its name from the Greek word lochia. At first the discharge is pure blood because it issues exclusively from the vessels left open by the removal of the afterbirth. The greater part of the blood flows out of the birth canal, but frequently some of it collects in the cavity of the uterus or of the vagina. There it coagulates, and the clots may not be expelled until several days later. In that event, as whatever effect the bleeding may have had has long since passed, the appearance of the clots is usually no occasion for alarm. The amount of lochia varies, and will likely fall below the average in small or anemic women and rise above it in those who are large or robust. Then again, the discharge is less profuse if considerable blood has been lost immediately after the labor. For the first 10 days the total quantity seldom exceeds 8 or 10 ounces. After that time it is so small that it cannot be accurately estimated. Formerly much larger amounts were considered normal, and therefore it is probable that modern aseptic treatment of childbirth has lessened the subsequent loss of blood. Toward the end of a week the lochia changes from a bright red to a brownish color, because the discharge now includes certain products of disintegration. Somewhat later the lochia consists almost entirely of mucus, being only streaked with blood, but there will be an increase in the bleeding when the patient gets up, and injudicious activity may cause flooding. A slight bloody discharge may be expected to continue until 5 or 6 weeks after the child was born. A faint but characteristic odor to the lochia proves very disagreeable to some patients, and on that account it was formerly customary to give them a daily douche throughout the lying-in period. This was before the characteristics of the puerperal uterus and the nature of infection were thoroughly understood. Most physicians are now convinced that the early use of douches is rarely beneficial, and since there is danger of washing infectious material from the lower part of the vagina into the uterus, they may, if given prior to the 2nd week after delivery, actually do harm. Consequently, douches are not now used in a routine way. Whenever irrigations are indicated, the doctor will prescribe them. Late in the puerperium, vaginal douches are unobjectionable, and patients may take them unassisted, for then the fluid will not penetrate the womb so long as it has a free escape from the outlet of the vagina. Moreover, it is immaterial if some of the fluid should pass into the womb, for its lining will have been largely restored by this time, and at points where restoration is incomplete, defenses have been thrown up against infection. The return of menstruation. On account of the dilatation at the time of labor, women who have previously suffered with menstruation may look forward to relief after childbirth. Menstruation generally becomes as painless as the flow of the lochia, and so far as a patient can tell, the two phenomena are identical. Actually, however, they bear no relation to each other. The fact that the cavity of the uterus has been deprived of its lining is responsible for the lochia, whereas the menstrual discharge occurs in spite of the lining, through which it breaks at regular intervals in response to a stimulus that is absent for a longer or shorter period after the birth of a child. In the latter part of the puerperium there may be doubt as to whether a discharge is menstrual or lochial, though if necessary an examination of the interior of the womb would always settle the question. For structural changes in the uterine mucous membrane form the most characteristic feature of menstruation. If, therefore, small bits of this tissue are removed and studied under the microscope, a definite conclusion can be reached. Physicians may resort to such an examination when the significance of a discharge is not clear without it, but other evidence usually enables them to decide the matter. The secretion of milk often exerts an influence upon the reestablishment of menstruation. Under ideal circumstances the mother does not menstruate while she nurses her infant, whereas if the breasts are not in use the menstrual function returns 6 to 8 weeks after delivery. Other pertinent clinical facts also lend weight to the opinion that the activity of the breasts, more technically called lactation, should not only prevent menstruation but also hinder the ripening of egg cells in the ovary. Thus the nursing infant has a potent influence upon the reproductive function of its mother, enabling it to preserve its food supply, for in the event of conception the milk usually decreases in amount or becomes of an inferior quality. To secure this protective influence should prove a strong incentive for the mother to nurse her child. In barely half the cases, however, is it effective throughout a year. 1/3 of nursing mothers, statistics indicate, begin to menstruate about 2 months after delivery, and month by month the proportion gradually increases. Since menstruation appears so frequently during lactation, it cannot be considered abnormal. It does not follow that the function will become permanently reestablished after a patient has menstruated once. In many instances several months elapse before there is another period, and in a few cases there will be only one period during the year the child suckles. Nevertheless, when the function has once made its appearance, extraordinary precaution should be exercised to avert a return, and about the time its reappearance would be expected, the woman should go to bed for several days. Although this measure may prove futile, we know of no other so likely to prove successful. Menstruation is more apt to return prematurely after the birth of the first child than of later ones. This may be due in part to a kind of accommodation of the maternal organism to the reproductive process as one pregnancy follows another. But I am convinced that it is also due in part to the greater physical and mental composure of experienced mothers. Until a woman has learned the unwelcome consequences, she is apt to take over household duties before she is equal to the task, or she may engage in too strenuous amusements, and most mothers err in a too energetic care of the baby. Other restorative changes. Many of the restorative changes in the mother's body are either so intricate or so devoid of practical significance that we may pass them by, though all of them have great interest for the specialist and some have occasioned bitter controversy. The alterations in the heart, for instance, have been the subject of a prolonged dispute between French and German scientists. The former still assert that this organ regularly enlarges during pregnancy and subsequently returns to its normal size. The Germans deny both these contentions. Certainly the alterations are insignificant from a practical standpoint, otherwise competent observers would not disagree. The really important changes in the body, other than those pertaining to the uterus, are familiar to women who have passed through pregnancy. But other prospective mothers may not understand that they will regain the bodily condition which existed before conception. Loss in weight. While the weight lost during the lying-in period is not so vital as some other alterations, many have a keen interest in it. In addition to the loss of 10 to 15 pounds at the time of birth, A further loss occurs in the course of a few weeks. Diminution in the size of the uterus is responsible for the loss of nearly 2 pounds, and the lochial discharge for at least another. But the chief factor concerned is the removal of water from the tissues, many of which have become dropsical toward the end of pregnancy. Altogether, patients do not lose less than 10 pounds during the lying-in period, and often lose a great deal more. The average loss for the first week alone is said to equal 1/12 of the patient's weight at the conclusion of labor. The total loss for the whole of the puerperium corresponds to 1/10 of her weight at the beginning of it. Variations from the rule are attributed to individual peculiarities of nutrition. In general, stout women lose more than slender ones, but with all types the loss is greater if the mother nurses her infant. On the other hand, a generous diet tends to counteract any loss in weight whatever. The abdominal wall. Much more important than the question of weight is the recovery of the abdominal wall from the strain imposed by the enlargement of the womb. In normal cases, to be sure, there is very slight disproportion between the size of the pregnant uterus at term and the capacity of the abdomen. Yet the abdominal wall invariably suffers a little stretching, and unless it retains its elasticity, the viscera are deprived of essential support and cause more or less discomfort. The restorative changes in the abdominal wall involve the skin, the fatty tissues, and the muscles. As soon as the distension has been relieved, the skin falls into folds, less noticeable if the pregnancy was the first, and the muscles become so flabby that one has no difficulty in pushing the wall backward until it touches the tissues which cover the spinal column. Within a few weeks, if all goes well, the muscles regain their tone. Coincidentally, the excessive fat over the abdomen is absorbed. The skin becomes smooth and its pigmentation fades completely, but the pregnancy streaks rarely vanish entirely, although they always become very much less noticeable. Whether or not the abdominal wall will recover from the distension of pregnancy depends entirely upon the muscles. As the lying-in period advances, each fiber should gradually shorten until the whole muscular structure becomes as firm and tight as it ever was. But this takes time, and no artifice can hasten the repair. Perfect recovery is most likely with the body in a recumbent position, which relieves the muscles from any strain. These facts are better appreciated than formerly, hence most physicians encourage their obstetrical patients to remain in bed somewhat longer than their mothers did. Generally nothing else will be required, and only under extraordinary circumstances will nature need assistance. Thus, if there has been unusual distension, as for example that due to twins, the muscular impairment may be extreme, or if pregnancies follow one another in quick succession, the strain becomes so nearly continuous that there is not sufficient time for adequate repair. Whenever nature does need encouragement, calisthenics of some kind are advisable. These systematic exercises, which the patient practices in bed and flat on her back, are usually begun about a week after delivery, though there may be some reason for beginning them earlier or later than this. The physician will always select the proper calisthenics, but the following movements generally prove satisfactory. To exercise the muscles at the front of the abdomen, one leg after the other is raised and lowered. As this is being done, the knee will be bent, flexed, at first, but later the leg may be held straight, extended. Other muscles come into play when the feet are alternately brought together and separated as widely as possible. A third movement, which exercises the muscles at the side of the abdomen, consists in raising the shoulders from the bed and twisting the trunk so that the weight of the chest rests now on the right, now on the left elbow. When these movements can be performed 15 or 20 minutes without fatigue, more vigorous exercises may be adopted. For example, the buttocks, together with the lower part of the back, are raised off the bed, while the shoulders, elbows, and the heels remain stationary. A day or so before getting up, the patient should practice alternately raising herself from the recumbent to the sitting posture and returning to the above position without assistance from the arms. The value of bandaging the abdomen immediately after delivery as a means of strengthening the abdominal muscles is questionable, though physicians agree to the advantages of a supporter after patients are out of bed. We constantly see perfect restoration of these muscles without the early use of a binder. In fact, women who have employed it throughout the lying-in period do not secure an efficient abdominal wall more frequently than others who began its use 2 weeks after they were delivered. Even those physicians who advocate an early application of the binder concede that it works harm in certain cases, and do not recommend it indiscriminately. Those who postpone for a fortnight the use of the binder will escape the tendency it has to cause displacements. By this time the involution will have advanced so far that the womb lies within the pelvic cavity, where it is surrounded by the hip bones, which protect it from external forces that otherwise would influence its position. When permitted to get up, patients ought to use a binder because it counteracts the feeling of falling to pieces, of which some complain when the abdominal walls are not comfortably supported, but there is no evidence to show that a binder plays any part in restoring the figure. When, in spite of ample rest, the abdominal muscles fail to recover completely, we have no better way of strengthening them than by use of calisthenics or massage. The pelvic floor. Second only in importance to having the womb restored to its original position is the necessity of restoration of the pelvic floor. This structure, also called the perineum, we should know lies between the thighs, shuts in the bottom of the abdomen, and prevents prolapse of the viscera. In women it forms the lower portion of the birth canal, enclosing the aperture through which the child enters the world. Although intelligent management of labor is of the greatest value for the protection of the pelvic floor, under certain circumstances it may be impossible to preserve it intact. Injury to it is the rule when the first child is born, and not unusual in later births. There can be no doubt regarding the advisability of uniting the edges of a tear. Indeed, to do so immediately is the very first essential toward restoring the pelvic floor to its wonted integrity. But even though tears are sewn up successfully, there is invariably some relaxation of the perineum until the restorative process, which here again chiefly concerns the muscles, has been given opportunity to become effective. As with all the restorative changes in the lying-in period, to rest calmly in bed favors the perfect recovery of the pelvic floor more than anything else. Keeping the thighs together during the first few days undoubtedly assists tears in healing, but that precaution is not always necessary, and when it is, the physician will call attention to the fact. The really important matter, as I have said, is that the upright position should not be resumed until the pelvic floor has become firm. The care of the patient. Now we have learned enough of the manifold changes in the lying-in period to appreciate the fact that patients require medical direction even though they are feeling perfectly well. The view held by former generations that women can get along without a doctor and with any sort of nursing is partly responsible for the existence of gynecology, the branch of medicine which deals with the diseases of women. Recently delivered women should be treated as surgical patients, not because they are ill, but to keep them from becoming so. If the patient desires the highest degree of protection, an experienced nurse is indispensable, for she will make systematic observations which would consume too much of the doctor's time for his personal attention, yet without which he would not be sufficiently conversant with his patient's condition to guide her properly. The temperature, the rate of the pulse, and of the respiration should be recorded at regular intervals during the day and night. An elevation of temperature at the conclusion of labor need give no uneasiness, for experience has shown that it generally subsides within a few hours. Moreover, slight elevations in the course of the following week are so frequent that obstetricians have agreed to regard as a normal temperature for this period 100.4 degrees, instead of the usual normal of 98.4 degrees. The pulse rate most frequently does not depart from what is characteristic for the individual, though about 1/5 of puerperal women have a slowing of the pulse, a phenomenon of favorable significance. Any difficulty in breathing that may have existed in the latter part of pregnancy disappears when the abdominal distension is relieved, and the respiratory rate becomes normal. So long as the body is getting rid of the tissue substance essential to pregnancy, but now without any purpose, more than the usual amount of waste material is present in the expired air. The elimination of waste material. As we might expect from the loss in body weight, the excretory organs are particularly active during the lying-in period. In quantity, the loss of water exceeds all the other waste products together, and pronounced activity of the kidneys or of the sweat glands may become a source of annoyance. Since it is undesirable to interfere with these functions, whatever inconvenience either may cause will be borne with less complaint if the patient understands that a large loss of water at this time indicates a healthful condition of the body. Shortly after delivery there may be difficulty in emptying the bladder, and under such circumstances the doctor or nurse used to catheterize the patient immediately. This habit once begun, it was often necessary to repeat the operation day after day, or for that matter several times a day. But as physicians came to know more of the relations of bacteria to inflammation of the bladder, they grew more cautious, and preferred to wait a long time before resorting to the catheter. The reward of this patience was to find that, with remarkably few exceptions, puerperal women ultimately void of their own accord. Accordingly, catheterization after childbirth is now postponed, and is never performed until a number of devices to get the patient to void spontaneously have been tried without success. Often urination follows putting a hot water bottle over the bladder, or pouring warm water over the vulva, or placing the patient upon a bedpan from which steam is rising. When these and other devices well known to every nurse are not effective, catheterization becomes necessary. With the elaborate precautions taken to avoid infection of the bladder, catheterization is now performed with very slight risk. Constipation, for various reasons, becomes a regular feature of the lying-in period. The confinement in bed, restricted diet, relaxation of the abdominal wall, and sensitiveness about the region of the rectum all have a tendency to prevent spontaneous movements of the bowels. As one of these influences after another is removed, the bowels begin to act naturally. Childbirth may cause chronic constipation, but this sequel would occur much less often if a little care were taken to prevent it. The routine use of enemas deserves to be condemned. I see no objection to an occasional enema if purgative medicine has been taken without effect, but constant use of them more than likely will result in the enema habit. Similarly, long continued administration of strong purgatives tends to make them a permanent necessity. While in bed, if medicine is taken every other day, the bowels will have opportunity on the intervening days to move spontaneously, though we do not really expect them to move naturally until 6 or 8 weeks after the delivery, when the patient is able to take as much exercise as she likes. Toward the end of the second week, however, mild laxatives generally prove effective, and it is important to select one the dose of which may be gradually decreased. Senna prunes, which were described in Chapter 5, fill the purpose very well. 6 or 8 of them may be needed at first, but the number may be gradually reduced until finally none are necessary. Cleanliness. In view of the excessive elimination of waste products from the body, the maintenance of cleanliness during the lying-in period may require the use of a large amount of linen. Occasionally, patients perspire so freely that the night clothes have to be changed several times in 24 hours, and the bed linen only a little less frequently. But at any cost it is imperative not to hinder but rather to promote this function, and to keep the skin in a healthful condition through bathing and massage. Nurses are taught, on this account, to give a warm soap and water bed bath in the morning and an alcohol rub at night. Patients are usually allowed to take tub baths after the 3rd week. Local cleanliness, which is a matter of the very first importance, can only be attained through bathing the vulva with an antiseptic solution and the use of sterile pads. At first the pads are changed very frequently, but after the discharge becomes less profuse they are renewed at intervals of 4 to 6 hours. The diet. For the first week of the lying-in period not all patients are given the same diet, and the physician always leaves specific directions regarding it. Generally the diet consists of liquids, such as milk and broths, for a couple of days. Under some circumstances liquid nourishment is continued longer. As the appetite increases, easily digestible but nutritious food is added, and before long the patient resumes her ordinary diet. The modern tendency is to give solid food and to give it in substantial amounts much earlier than was once customary. Restrictions none the less are still observed so long as the patient remains in bed. With the body at rest, its food requirements are diminished and hearty meals are unnecessary. If convalescence proceeds satisfactorily, such wide latitude in the choice of food is permissible that the nurse may regulate the diet, consulting the physician whenever necessary. The environment. A large, bright room that can be quickly heated and easily ventilated adds notably to the comfort of the lying-in period. The windows may be opened through the greater part of the day, and at night should always be left so. To make thorough airing of the apartment more feasible, and to protect the mother from annoyance when the baby cries, it is more satisfactory to have the baby occupy an adjoining room, where the nurse sleeps within call. Under any circumstances some arrangement must be made so that the mother's rest at night will not be broken needlessly. No pains should be spared to keep the patient quiet for at least 10 days. Household cares and petty worries materially delay convalescence. During this period only a limited number of the immediate members of her family ought to see her, and their visits should be brief. Unfortunately, if too many relatives and friends visit her, a number of questions will be repeatedly asked which are decidedly wearing on any patient. The time for getting up. How long a woman should stay in bed after the birth of a child is a question which has given rise to prolonged discussion. The majority of obstetricians adhere to the traditional 10 days, but there are advocates of a longer period and advocates of a shorter one. The generalizations of many writers upon this subject are too sweeping, for exceptions may be found to any rule. Each patient is best counseled when the advice given is based upon her own condition, and particularly upon the progress made in the involution of the uterus, which does not advance with the same rapidity in all cases. More or less in imitation of the custom among savages, Charles White, in 1776, recommended that women should not remain in bed longer than a day or two after childbirth. Very likely the inadaptability of the method to civilized women soon became apparent. At any rate, his suggestion was not widely adopted, and had been completely forgotten until a few years ago, when the custom was revived in one of the German clinics. The innovation met with violent opposition in Europe, and, so far as I know, has found but scant favor in America. Generally patients are allowed to sit up in bed toward the end of the first week, but if there are stitches, sitting up is deferred until 10 days or later, when the stitches have been removed. Under the most favorable circumstances, however, sitting up in bed becomes wearisome, for the weight of the body does not fall upon the spine as it should, and besides, the extended position of the legs is fatiguing. No one should force herself to keep this posture, for at best it does no more than relieve monotony. The exercises previously suggested prepare her much more effectually for getting upon her feet. Between the 10th and the 15th day, patients may leave the bed and sit quietly in a chair. The condition of the uterus, the character of the lochia, and the firmness of the pelvic floor will determine the day, but usually it proves wiser to defer it until fully 2 weeks have lapsed. As a rule, the patient remains out of bed an hour the first day, 2 the second, 3 the third, and so on until she's up all day. She should not attempt to walk until the second or third day. At first she should take only a few steps, but gradually she may increase the number and finally walk with freedom and ease. Several reasons make it advisable for patients to remain 4 weeks on the floor where they have been confined. Going up and down stairs is especially tiresome, and of still greater importance, patients pass from the doctor's control as soon as they go down stairs. For fear of overtaxing the strength, none of the household cares should be assumed before the 4th week, and not all of them then, for women are not capable of resuming their accustomed duties fully until the 6th week, and some are not strong enough to do so until a somewhat later date. Since patients generally feel well during the lying-in period, they are apt to object to remaining in bed 2 weeks. Most of them acquiesce as soon as they understand the organic changes in progress and appreciate the lasting benefits of a temporary forbearance. But a few must be made to realize that very serious penalties may be attached to undue haste. For the latter, it might be better if the alarming consequences of getting up too early, discomfort, hemorrhage, and collapse, occurred more frequently than they do. As it happens, the ill effects of such indiscretion are not usually felt immediately. When too late, the lesson is learned that many of the operations upon women in the later years of life are dependent on imprudent conduct just after the first child was born. The final examination. Looking to complete restoration of the woman's health, the modern management of obstetrical cases breaks decisively with tradition at 3 points. An utter disregard of precaution has given way to very careful preparations before and at the time of labor. Definite rules for the management of the lying-in period are carried out under the supervision of the physician. And finally, prompted by the same impulse, the physician examines his obstetrical patients before discharging them. Satisfactory conditions are generally found. If they are, it is a great comfort to be assured of the fact, and if not, timely treatment of the abnormality may readily correct it. With delay, on the other hand, treatment often becomes more formidable. The end of the 4th week of the lying-in period proves a convenient time for this examination. As yet the restorative changes in the reproductive organs have not been completed, but one may definitely say by this time whether or not they will culminate in a satisfactory manner. Besides, making the examination while the changes are in progress sometimes enables the physician to treat approaching complications before they actually develop. Thus, when the pelvic floor has not regained its strength sufficiently, the patient will be advised to forego the liberty in moving about ordinarily granted at this time. When the womb inclines to an improper position, a temporary support may be introduced to hold it where it belongs. Later, upon removing the device, the womb usually retains a good position. Again, there are conditions which a douche will relieve, and still others benefited by medicinal treatment. If an abnormality is recognized which cannot at once be treated to the best advantage, arrangements will be made for such prompt treatment that the woman will not become an invalid. Instead of placing obstacles in the way, patients should rather insist upon this examination, for it is important in guarding their future health. Now and then patients are kept under observation for a longer period, but as a rule they are discharged as well as examined at the end of 4 weeks. They may also discard the abdominal binder about this time and put on corsets, which, however, should not be tightly worn. Although thrown upon her own resources from this moment, the patient will clearly understand that she must continue to exercise sound discrimination in what she does. And here, of course, we encounter the greatest difficulty in offering practical advice, for what one may do easily will overtax another. Generally speaking, going up and down stairs more than once a day is inadvisable until another 2 weeks have passed. Likewise, the mother who would adopt a conservative policy will not take full charge of her baby before it is 6 weeks old, though there can be no objection if she wishes to direct its care. The same advice applies to running the household. Overexertion, no matter what the source, delays convalescence from childbirth to such an extent that the safe plan is always to err on the side of doing too little rather than to run the risk of doing too much. End of Chapter 11. The Lying In Period. Recording by Pamela Krantz. Section 16 of the Prospective Mother. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Pamela Krantz. The Prospective Mother by J. Morris Slemons. Chapter 12. The Nursing Mother. The breasts, human milk, the technique of nursing, hygiene of the mother, diet, psychic influence, recreation and rest, the supplementary bottle, weaning. When the obstetrician pays his final visit, the mother usually has ready a number of questions, most of which anticipate difficulties in the care of the baby. At that time, however, minute and far-reaching directions cannot always be given. Unforeseen peculiarities in the development of the child may modify such general principles for the management of infants as could be laid down in advance. With a few exceptions, therefore, mothers require during the early years of a baby's life skilled advice as to his upbringing, advice for which neither instinct nor haphazard counsel is a safe substitute. It is an excellent plan, and one which is becoming more and more popular, to have a physician supervise the care of the baby through the period of most active growth. According to this plan, the mother, even though her baby is well and developing as it should, consults the physician at regular intervals, once a month for example, and upon these occasions secures help in solving problems which are certain to present themselves. Such an arrangement shows a merited appreciation of the proverbial ounce of prevention, and when serious difficulties do arise materially counteracts the tendency to panic which is exhibited by so many young mothers. Among the problems which the mother must solve, that of nutrition outranks all others in importance, and unless the infant is nourished with human milk, it also exceeds them in perplexity. For although great advances have been made in artificial feeding, science has not yet removed all the intricacies and dangers involved in the use of the bottle. On the other hand, mothers who nurse their babies rarely meet with difficulty. Human milk is perfectly adapted to the wants of the infant, and all substitutes, though carefully designed to duplicate it, are only partially successful. We have learned how to modify cow's milk so that in chemical constituents, at least, it is a very close imitation of human milk, but human milk possesses, in addition to its chemical properties, other desirable qualities which cannot be instilled into an artificial food. We must agree, therefore, that attempts to disseminate a wider knowledge of the correct principles of bottle feeding do not have the highest aim. Our real need is a vastly greater proportion of women who nurse their children. The breasts. For success in nursing, the first essential is healthful breasts. With this, the largeness or smallness of a breast has nothing to do, for size is no more an index of its capacity for producing milk than is the weight of a woman an index of her energy. The breast is not a warehouse, but a factory, with very limited storage capacity for its product. Differences of size are generally to be explained by the variable amount of fatty tissue the breast contains. And so far as the secretion of milk is concerned, the fat is entirely passive. It fills in the space between the glandular elements, and a layer of fat just beneath the skin protects the glands against external influences that otherwise might disturb their activity. Stripped of their fatty envelope, the structures which actually secrete the milk and convey it to the nipple resemble a miniature cluster of grapes. Each tiny spherical gland corresponds to one of the grapes and contains a cavity lined with cells which manufacture the milk. From this cavity the milk flows through a microscopic tube which unites with similar tubes to form a larger one. This in turn joins others of its kind, and so on until ultimately the milk enters a relatively large duct, the figurative stem of the cluster, which conducts the milk to its destination. There are from 10 to 15 of these terminal ducts; each drains a separate group of glands, but all end in the nipple. Shortly after conception the breasts become congested. In consequence they enlarge, become tender, and begin to show swollen veins beneath the skin. The most significant alteration, however, occurs in the cells which line the glands. These increase in size at first, and then, by a process of cell division, their number multiplies. After pregnancy has advanced 6 to 8 weeks, these cells begin to elaborate the thin, watery fluid called colostrum. Contrary to popular belief, the quantity of colostrum is not prophetic of the character of the milk. There is no ill omen, to be sure, in a plentiful secretion, but a meager one is quite as likely to be followed by successful lactation. At present we are unable to predict by any means either the quantity or the quality of the milk which a prospective mother will produce. Some writers contend that influences which come into play during girlhood ultimately affect the capacity of the breast for making milk. For example, irregular habits in youth and the wearing of improper styles of clothing are said to be particularly detrimental influences. Of course, a healthful mode of life at the time when a girl is approaching maturity reacts favorably upon her development in every way, and naturally enough the breasts share this benefit. But the relation between unhygienic habits at about the time of puberty and a subsequent deficiency in lactation has been exaggerated by many writers. It is impracticable, certainly, to institute special measures to prepare the breasts for their function until the need of such measures is clearly evident. Throughout pregnancy, clothing about the breasts should be loosely worn. If the nipples are not already prominent, they should be drawn out, and about 6 or 8 weeks before confinement is expected they should be given the treatment described in Chapter 5. For the first day or so after the infant begins to nurse, its efforts have a tendency to injure the skin which covers the nipple, and unless measures to render the nipple resistant have been previously adopted, nursing may cause the mother considerable discomfort. Moreover, it is extremely important throughout lactation to keep the skin covering the nipple free from abrasions, for if it cracks, bacteria have thus an opportunity to enter the glands and set up an acute inflammation, which may result in the formation of an abscess. This complication is to be avoided, not only because of the unpleasant symptoms which attend it, but also because for the time it brings the usefulness of the breast to an end. Fortunately, an abscess seldom impairs the breast permanently. At any period of lactation there may be an overproduction of milk. In this event the breasts are likely to become distended, hard, and very tender. Most frequently caked breasts, as this condition is called, develop a few days after delivery, when the secretion of milk is just beginning, for at first the secretion is more plentiful than need be. Generally 24 hours later there is an adjustment between the supply of nourishment and the natural demands of the infant. Occasionally a longer interval elapses before the breast is completely emptied at each nursing. Formerly it was customary, whenever the breasts became tense and uncomfortable, to express an excess of milk by means of massage. But this mode of treatment lost favor as soon as physicians realized that massage stimulated the glands to greater activity. Drawing the milk with a breast pump has a somewhat similar though less potent influence, and because pumping often affords relief when the breasts are distended, there is rarely any objection to it. In the light of modern experience, however, most physicians prefer to avoid manipulation of the breast so far as possible, and generally resort to other measures to relieve the mother's discomfort. Thus most patients are made comfortable if an appropriate bandage is used to transfer the weight of the breasts from the armpits and the front of the chest to the bones of the shoulder girdle. It may be necessary also in some cases to swathe the breasts in warm cloths. In others, cold applications are more acceptable. The choice between these methods will vary with the time of year, and usually may be left to the patient herself. Now and then medicine will be employed to relieve the pain, but the administration of drugs to diminish the production of milk is inadvisable. It is never very long before the amount of milk becomes adjusted to the infant's wants, and then distension disappears spontaneously. No artifice can bring about the adjustment as ideally as nature does. During the later months of lactation the liability of the breasts to overfilling is slight, provided the infant empties them regularly and completely. Nevertheless, so long as a mother is nursing her child, she must be careful to keep the breasts in a healthful condition. They require support, yet must not be compressed, and they should be covered with clothing which will adequately protect them from sudden changes of temperature. This latter precaution, perhaps, requires more emphasis than formerly, on account of the present popularity of motoring, for the chill which one experiences when driving fast may have a very unpleasant effect upon a nursing mother unless her breasts are carefully protected. Occasionally fever and neuralgic pains in the breasts are caused by motoring, or by exposure to the air current from an electric fan playing directly upon them. But even under these circumstances an abscess need not be feared unless the nipples are sore. Human milk. Between the time of birth and the beginning of lactation there is always an interval during which the breasts secrete colostrum, just as they do throughout pregnancy. Although the nutritional value of this fluid is not great, it is doubtful if colostrum serves any other essential purpose than as nourishment. Possibly it also stimulates the intestines to expel the material which is collected within them during fetal development. Yet we know the bowels will move without a purgative, and often do so long before the infant is placed at the breast. Typically the secretion of milk begins the third day after delivery, yet in perfectly normal patients it may appear as early as the second or as late as the fifth, and occasionally lactation does not begin until the baby is more than a week old. As to what starts the secretion of milk we have only a vague idea, but we know that when the flow is once established, its continuation depends primarily upon the sucking efforts of the infant. If nursing is discontinued, the secretion dwindles and the breasts dry up. On the other hand, the strong, persistent stimulus of the infant's suckling gradually brings the secretion to a high degree of efficiency. Within the first 2 weeks, therefore, the daily secretion increases from a few ounces to a pint or more. Subsequently, the output fluctuates between 1 and 2 quarts daily, according to the demands made upon the breasts. The secretion is larger, consequently, if there are twins. Astounding yields of milk have been recorded, as in the case of a wet nurse in a German institution who nursed a number of infants and became capable of supplying 3 to 4 quarts daily. That newborn infants thrive better on human milk than on any other nourishment is a conviction that must come home to every one who has had even a limited experience. It keeps the babies in health, serves to make them grow, and promotes the development of all their organs as nothing else will. Because there are present in this fluid all the elements necessary for nutrition, physiologists have called it a perfect food. Quantitatively its most important ingredient is water, which constitutes about 86% of its weight. It also contains about 7% of milk sugar, 4% of butterfat, 2% of protein, and 0.2% of mineral matter. The milk of all animals contains a relatively small quantity of mineral matter. Judged from this standpoint, the mineral matter would seem of minor importance, but it is actually as vital as any other constituent. Without it the bones would not harden properly, and other services which it performs are absolutely essential to life. As we should expect, human milk contains all the mineral ingredients necessary for the development of the infant. Indeed, with the single exception of iron, they are present in the precise amounts in which they are needed. In this omission, however, nature is guilty of no oversight, since the infant has already been provided by the time of birth with a rich supply of iron. The technique of nursing. Since the mother should have opportunity to recuperate from the fatigue of labor, physicians generally recommend that an interval of at least 12 hours elapse between the birth of the infant and the time it is first put to the breast. Moreover, the best interests of the infant demand that it be kept warm and left undisturbed while becoming accustomed to its new environment. There is no immediate need of food, and if there were, nature does not fit the mother to supply it, for at this time the breasts contain merely small quantities of colostrum. Some babies nurse vigorously at the outset, but later, discouraged because they get so little, become indifferent and restless, or even decline to take the breast, and the mother, who is handicapped by inexperience and by the awkwardness of nursing in a recumbent position, often feels desperate. Fortunately, technical difficulties are confined to the first few days, and, trying as they sometimes are, no one should be discouraged or imagine that she is incapable of nursing, for practically every woman who persists will succeed. For a week or 10 days the mother will nurse in the recumbent posture. She turns to one side or the other according as the right or left breast is used, and holds the corresponding arm to receive and support the baby, which will lie beside her. Then with the opposite hand she holds the breast, placing her thumb above and her fingers below so as to keep it from the baby's face, for only in this way can the infant breathe freely. One must also remember that the infant draws the milk into the terminal ducts chiefly with the back of its mouth, and drains the ducts by compressing the base of the nipple with its jaws. The infant, therefore, should take into its mouth not only the nipple but also the areola, the area of deeply colored skin round about it. Mothers frequently disregard these directions, and the failure of their infants to nurse properly may be thus explained, for it is impossible to secure undisturbed nursing unless they are obeyed. Generally the breasts are employed alternately, but both may be used at each nursing if one is insufficient. To fix the duration of the nursings arbitrarily is impossible. From 10 to 15 minutes generally proves satisfactory. But in each case, systematic observations of the change in the baby's weight, of the character of its stools, and of its general condition must determine how long to leave it at the breast. The common error, unfortunately, is to be overindulgent, and as a result, infants are more frequently ill because the nursings are too long than too short. Furthermore, the duration of the feedings can never be gauged accurately if the infant is allowed to nap while nursing. The successful training of a baby begins with the development of regular habits of nursing. The old-fashioned custom of allowing the baby to nurse whenever it cried, tacitly and incorrectly assumed that it could have no other sensation than hunger. As a matter of fact, an infant may have pain from overfeeding. Again, it may be thirsty or uncomfortable from the pricking of a pin, from the monotony of one position, from a soiled napkin, or from neglect of many simple details in its care. Any of these things make a baby cry, for it has no other means by which it can express disapproval. So long as the breasts contain colostrum, the nursings should be at least 3 hours apart during the day. At night it is preferable not to disturb the mother at all. As soon as milk appears, the interval is usually shortened to 2 hours during the day. In many cases, however, the 3-hour interval will be retained even after the milk appears, for otherwise the infant may not become hungry, and will fail to nurse as strongly as it should. The following schedule is adapted to the average infant: age from first to fourth week, interval during the day 2 hours, total number of feedings 9. Age from fourth to eighth week, interval during the day 2½ hours, total number of feedings 8. Age from second to fourth month, interval during the day 3 hours, total number of feedings 7. Age from fourth to 10th month, interval during the day 3 hours, total number of feedings 6. Age from 10th to 12th month, interval during the day 4 hours, total number of feedings 5. After the first few days most young infants require one feeding in the middle of the night, which is usually given about 2 a.m. The day feedings then begin at 6 a.m. and are repeated at regular intervals until 9 or 10 p.m. The daily bath should be scheduled so that a feeding will be due just after the bath has been completed. If asleep when the next succeeding feeding falls due, the infant should not be waked, but at other times nothing should interfere with the regularity of the schedule. Occasionally there may be difficulty in getting the child to nurse during the day, but it must be taught to do so, otherwise it will want to nurse throughout the night. At no time should an infant remain in the bed with its mother after it has finished nursing. At night this rule must be rigidly enforced, for mothers have been known to fall asleep and smother the baby, an accident known as overlying. Infants can frequently be trained to go without feeding in the middle of the night even when a month old, and such training is always advisable, since it affords the mother opportunity for 6 or 8 hours continuous sleep. Before and after each nursing, the mother's nipple should be cleansed with a solution of boric acid made by placing a tablespoonful of the powder in a tumbler which is then filled with water. Such cleansing protects the breasts against infection, a complication which the nursing mother must spare no pains to prevent. Now and then, in spite of conscientious efforts to harden them, the nipples become sore. If they crack, the baby's mouth must not come in direct contact with them, since nursing with a cracked nipple is a common source of a gathered breast. Fortunately, when a nipple cracks, we may employ a shield, obtainable at any drug store, which enables the infant to nurse without any danger to the mother. Most babies will take the shield as well as the breast itself. Nevertheless, its use should be discontinued as soon as the nipple heals, for while the shield is used, the secretion of milk is not stimulated as vigorously as when the infant nurses directly from the breast. In the rare cases in which the shield cannot be used satisfactorily, the infant must be taken from the breast temporarily and given a bottle. Radical as this advice may appear, the mother must consent to follow it, for, as I have pointed out, to permit an infant to nurse a cracked nipple is extremely hazardous. When treatment is begun promptly, the cracks will generally heal within 24 hours. Hygiene of the mother. Since the mammary glands manufacture their product from the constituents of the mother's blood, and their activity is controlled by her nerves, it is clear that her physical condition and her state of mind will influence the secretion of milk. Intelligent women who understand this desire to know how they should live that they may best ensure an ample supply of good milk. Fortunately, the first important step toward success has been taken when a mother wishes to nurse her baby. But there are also necessary wholesome food, habits conducive to health, and a mind free from worry. It is unfortunate that current beliefs throw many restrictions about nursing mothers which are unreasonable and unsupported by scientific investigation. There was a time when mothers did not question their ability to nurse; they assumed this duty as a matter of course. Indeed, they were compelled to do so, since refined methods of artificial feeding had not as yet been devised. Among the agricultural class even to day it is exceptional for mothers to fail to nurse their children, if they are provided with the ordinary comforts of life. But women who live at the higher tension of city life are frequently unsuccessful, because they are more inclined to be nervous, or because they disregard, among other things, the need of fresh air, plain food, or regular habits. It is wrong to suppose that elaborate rules of conduct are necessary for nursing mothers. The instruction they require is simple and scarcely different from that to be given any one who desires good health. If she lead a wholesome existence, a woman will not only nurse her child successfully, but will gain in strength. Diet. In manufacturing centers, where a large proportion of the women are employed in confining work, the percentage of mothers who are able to nurse their children is exceedingly small. Consequently, the infant mortality is very high. Better nourishment for the mother, it has seemed, would render her more capable of successful lactation, and would decrease or even eliminate badly executed artificial feeding, and would therefore reduce the death rate among the babies. In a few foreign cities the idea has been put into practice. Free restaurants have been established for working mothers, and they have thus been enabled to perform their maternal duties much more successfully. Incidentally, it has been shown that nourishment may be supplied mother and infant at a smaller cost than proper artificial food for the infant alone. The quantity of nourishment required by nursing mothers is not so large as might be expected, and in many instances it is overfeeding rather than underfeeding that must be guarded against. Very accurate observations have been made which indicate that during the early weeks of nursing no more food is needed than at other times. In all probability this remains true throughout the whole period of lactation. Overeating, as many of us know, is a frequent cause of indigestion. It is of the first importance, therefore, that nursing mothers should not take more food than they can assimilate, for indigestion will provoke disturbances in the milk, which in turn will make the baby uncomfortable. For a similar reason, mothers should have their meals at regular intervals. As a rule, the appetite is a reliable guide not only as to how much to eat, but also as to the choice of food. For without exception what is good for the mother is good also for the child. Generally the diet should be a mixed one, consisting of milk, gruels, soups, vegetables, bread, and meat. In order that monotony may not dull the appetite, no one article of food should be employed continuously. With this exception, food should be selected with regard only for its wholesomeness and digestibility. All food is milk-making food. No sharp distinctions between the various kinds can be recognized. Milk, because it contains all the elements necessary for perfect nutrition, is particularly wholesome. Water also, since it forms such a large proportion of their milk, should be taken freely by nursing mothers. Generally it proves advantageous to take milk or some other nutritious drink between meals and again before retiring at night. But the danger of ruining in this way the appetite for solid food must not be overlooked. It ought to be unnecessary to say that a nursing mother should deny herself any article of food, no matter how much she may want it, if she knows it will disagree with her. But she must remember also that the same article of food will not necessarily disagree with other mothers. Generalizations of this kind are largely responsible for the wrongful tendency to reject from the dietary many altogether harmless articles. There would be little left for a nursing mother to eat if she avoided every article of food which one person or another assures her will damage her milk. No belief regarding what a nursing mother should eat is held more widely, I suppose, than that she should abstain from salads, tomatoes, and fruits which contain acid. This view is erroneous. The very idea upon which it is based is incorrect, since acids are neutralized as soon as they pass from the stomach to the intestines, and cannot enter the milk. With certain persons some varieties of fruit invariably cause indigestion. Lactation does not correct such an individual peculiarity, and a nursing mother who knows she possesses it will act accordingly. Occasionally those who have no such idiosyncrasy worry after they have eaten something which contains an acid because they have heard it will do harm. In such cases it is the mental state of the woman which disturbs her milk and upsets the baby. With the exception of those who have such an idiosyncrasy and those inclined to worry, nursing mothers may partake of fruits and salads with impunity. There are vegetables, of which the onion and turnip are good examples, that contain ingredients that find their way unaltered into the milk. So long as these do not disturb the mother, their presence has no unfavorable influence upon the child. Similarly, a number of substances appear in the milk when administered as medicine to the mother. In one way this is fortunate, for under certain circumstances it provides a very satisfactory method of treating unhealthy children without giving the medicine directly. In another respect, however, it is a disadvantage, for it sometimes interferes with giving the mother purgatives, which she may need. So far as possible, therefore, the taking of medicine should be limited during lactation, and certainly no drug should be employed without the advice of a physician. Time and again some drug, some beverage, usually one that contains alcohol, or some special article of food has been recommended as a means of increasing an inadequate secretion of milk, but thus far all attempts in this direction have failed of general application. There are at present on the market widely advertised preparations for which astounding efficiency is claimed. None of them, however, has a definite or consistent value, and it is unfortunately true that no substance has yet been discovered that has the specific action of increasing the production of milk. Psychic influence. Although the nerves of the breast, which regulate the secretion of milk, do their work whether the mother wills it or not, her state of mind has an influence over the process, just as it has over digestion. No one doubts that our minds influence our digestions, as has been so clearly proved by the skillful experiments of Pawlow, an eminent Russian physiologist. Cheerfulness promotes perfect assimilation of the food, whereas mental depression decreases the secretion of the digestive juices or checks them altogether. In a similar way, perhaps, we shall some day have explained to us the unquestioned fact that mothers who maintain a happy disposition nurse their babies efficiently, while those who are inclined to worry often experience real or imaginary troubles with lactation. The most striking manifestations of such psychic influences are those in which, as a result of some strong passion or deep sorrow, the secretion of milk suddenly ceases altogether. Fortunately, such effects occur rarely and are never permanent. After a few hours at most the secretion is reestablished, and if there are alterations in the quality of the milk, these will correct themselves just as quickly. More common, and therefore much more important, are cases in which, because the mother allows herself day after day to worry over one thing or another, the secretion of milk suffers permanent disturbance in quantity or in quality. Sometimes worrying lest the milk will be unsatisfactory causes it to become so. Generally, however, unnecessary anxiety for the baby is to blame. Again and again, when there is really nothing out of the way, inexperienced mothers make themselves miserable because they fear something may go wrong. Such a state of mind always invites trouble. Not infrequently it is the direct cause of insufficient or unwholesome milk. The self-assurance gained through taking care of the first baby is responsible more than anything else for the greater success mothers have in nursing subsequent children. The mother who is nursing her first baby should take success for granted and never mistrust her ability to succeed. If the physician has been asked to visit the baby regularly, as was suggested at the beginning of this chapter, he will quickly detect the evidence of failure, should failure be imminent. His opinions should be accepted and his directions followed, for by so doing the mother will most readily acquire the assurance which is so necessary to success. The habit easily fallen into of paying attention to promiscuous advice is unwholesome, for such advice is injudiciously given and is usually incorrect. More often than not the counsel of well-meaning friends only serves to perplex and distress the mother. Recreation and rest. Next to worry, no influence upon lactation is more detrimental than neglect of recreation and rest. Both are very necessary to a nursing mother, for without them she will soon begin to exaggerate minor troubles and even to worry though nothing is wrong. A mother who has the care of a baby added to other responsibilities may have extraordinary difficulty in finding time for outdoor exercise, for congenial companionship, or for diversion of any kind. Occasionally it may seem almost impossible even to get time for sleep, a necessity so fundamental to health that, as we should expect, a mother deprived of it would fail utterly in nursing her infant. Difficult as it may seem, however, the mother must find time for recreation, for if she does not there will follow disturbances, generally in the quantity or sometimes in the quality of her milk. Keeping in mind that whatever benefits the mother will react favorably upon the infant, one should regulate exercise during lactation with regard to the kind and the amount of exercise to which she has been previously accustomed. Walking usually fulfills all the requirements satisfactorily, and there is ordinarily no reason why nursing mothers should not participate in sports that are unattended by violent exertion. Exhausting sports, however, must be shunned, because fatigue has the same injurious effect upon the secretion of milk as lack of exercise. As might be expected, women who are frail are most susceptible to the strain of nursing, especially if they fail to get sufficient rest. All nursing mothers ought to have at least 8 hours of sleep in the 24. The night feeding, generally advisable for the first 6 to 8 weeks, does not break the mother's rest longer than half an hour, if the baby is well trained. But if a baby that has not been properly trained turns night into day and keeps the mother awake for long intervals, the milk will quickly deteriorate. Under such circumstances some one must relieve the mother of the care of the infant during the night. She should not be disturbed even to nurse it. The night feeding will then be supplied artificially, as will also one feeding during the day in order that the mother may have opportunity for exercise and diversion. The supplemental bottle. At first glance it may seem that in the suggestion that the infant be given one artificial feeding each day the mother's comfort alone has been considered. As a matter of fact, however, the adoption of the plan benefits mother and infant alike. The diversion and recreation which the mother, thus relieved of her maternal duties for from 4 to 6 hours, has time to secure, becomes a direct benefit to the infant. Not infrequently by pursuing this plan, mothers who would otherwise be incapable of nursing are assured successful lactation. The child, moreover, having thus become accustomed to the bottle, is much more easily denied the breast when the time for weaning comes. Objections have been raised to giving the baby even one bottle when the mother has an ample supply of milk, but none of them are valid. Since cow's milk is acknowledged to be less easy of digestion than is human milk, it will occur to someone that there is danger of upsetting the baby by giving it a bottle. But this need not be feared. Extensive experience has shown that if an infant is getting human milk of satisfactory quality at all its feedings during the 24 hours, save 1 or 2, at these times it will digest properly modified cow's milk without the least inconvenience. Nor is it true that if once a day cow's milk is substituted for that of the mother, the infant will come to prefer the bottle to the breast. There is no danger, on the other hand, that the mother's milk will dry up. Very thorough investigation of these objections has failed to substantiate them in the least. Of course, it will be necessary in preparing the supplementary feeding to take the same precautions as if the infant were on the bottle exclusively. To avoid contamination of the milk, care must be exercised to have everything perfectly clean that comes in contact with it. And it will be necessary also to vary from time to time both the strength and the amount of the feeding. These alterations will be made most successfully if left to the judgment of a physician who is familiar with the development of the infant and who may be guided accordingly. Weaning. Occasionally, even before they are delivered, women express the conviction that they will be incapable of nursing. A few mothers who take this attitude, which it would seem is becoming more and more common, make no attempt at nursing, and others give it up after a very short trial. Premature weaning is practiced among the women of two widely different classes: those who are unwilling to deny themselves social pleasures, and those who, because they must earn a living, cannot be encumbered with maternal duties. A still larger class, however, are those mothers who wean the baby for neither of these reasons, but rather because they become discouraged and conclude that there is something wrong with their milk. In this way many infants are weaned without sufficient reason. Before giving up nursing her child, a mother should submit several samples of the milk for analysis. If it is unfit for the infant, reliable evidence of the fact will often be secured in this way. With the exception of tuberculosis, physicians recognize no condition that necessarily unfits a mother for nursing. As we have already seen, pregnancy is generally incompatible with lactation. In the event of conception, the mother's milk almost always takes on qualities which render it unsatisfactory for the infant, and yet occasionally pregnancy advances several months before these changes in the milk occur. Meanwhile the infant suffers no inconvenience, and often in these cases the symptoms of threatened miscarriage give the first intimation of the mother's condition. Under all circumstances, however, nursing should cease as soon as the mother recognizes that she is pregnant, for probably no woman is strong enough to provide nourishment for her infant and for the development of the embryo simultaneously. Menstruation, on the other hand, rarely, if ever, provides a good and sufficient reason for weaning. In the great majority of instances this function is reestablished before lactation ends. There may be a reduction in the amount of milk during menstruation, but if the infant has been given the breast as usual, the supply increases as soon as the period ends. Qualitative disturbances which would render the milk unfit for use are practically never a consequence of menstruation. It may happen as the infant grows older that the flow of milk will diminish. Then the breast feedings will of necessity be more frequently replaced by the bottle, and the question of weaning will settle itself. But if the time of weaning is a matter of choice, it should be approximately coincident with certain notable developments in the infant's digestive functions, which occur toward the end of the first year. The fact that the infant is prepared to take other food is outwardly shown by the appearance of teeth, of which there are usually 6 or 8 at the end of the year. If the suggestion regarding the daily substitution of one bottle for the mother's milk has been adopted, there will be no difficulty in discontinuing breastfeeding whenever it is desirable. Otherwise an infant may raise strong objection to the change. The mother, on the other hand, will not be seriously inconvenienced by the weaning, provided she leaves her breasts alone. Until recently mothers were advised to employ a very elaborate treatment for drying up the breasts. The diet was restricted, and as far as possible liquids of every kind were forbidden. Strong purgatives were administered daily, and in addition the breasts were covered with some ointment, swathed in cotton, and tightly compressed with a bandage. Fortunately, we now realize that none of these measures are required. When nursing is discontinued the breasts are apt to become distended and uncomfortable. They require support while the distension lasts, which is never very long, and if they become painful, medicine may be employed to give relief. But other measures, some of which occasionally do harm, are absolutely unnecessary. for at whatever period of lactation the breasts cease to be used, they dry up spontaneously. End of Chapter 12. The Nursing Mother. Recording by Pamela Krantz.
Glossary of the Prospective Mother. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. The Prospective Mother by J. Morris Slemons. Glossary. Footnote: The Century Dictionary has been freely used for these definitions. Abnormal. Irregular, deviating from the natural or standard type. Abortifacient. Whatever is used to produce an abortion. Abortion. The expulsion of the embryo during the first 4 months of pregnancy. Afterbirth. The mass of tissue expelled from the uterus at the end of labor. It includes the placenta, the umbilical cord, and the membranes of the ovum. Alimentary canal. The digestive tract. It begins with the mouth, includes the stomach and the intestines, and ends with the rectum. Amniotic fluid. The liquid enclosed within the amniotic membrane. Amniotic membrane. The innermost of the 2 membranes which envelop the embryo. The lining membrane of the closed sac familiarly called the bag of waters. Anemia. A deficiency of some of the constituents of the blood. Anatomy. The science which deals with the structure of the body. Antiseptic. Anything which destroys bacteria. Areola. The colored circular area about the nipple. Artery. A vessel through which the blood flows away from the heart. Asepsis. The exclusion of disease-producing bacteria. Aseptic. Free from injurious bacteria. Asphyxia. The extreme condition caused by lack of oxygen in the blood, brought about by interrupted breathing. Assimilation. The process by which living creatures digest and absorb nutriment so that it becomes part of the substance composing them. Atrophy. To waste away. Auto-intoxication. Poisoning by material formed within one's body. Bacteria. The plural of bacterium. Exceedingly minute, spherical, oblong, or cylindrical cells which are concerned in putrefactive processes. Some varieties cause disease. Bacterial decomposition. Putrefaction brought about by the action of bacteria. Biology. The science which deals with the phenomena of life. Birth canal. The passage through which the child enters the world. It is composed of the uterus and the vagina, and is surrounded by the pelvic bones. Bladder. A thin, distensible sac acting as a reservoir for the urine between the time it is secreted by the kidneys and leaves the body. Breech. The buttocks. Caesarean operation. The operation by which the child is taken out of the uterus by an incision through the abdominal wall. Calorie. The unit ordinarily employed by scientists to measure heat. Capillaries. The minute blood vessels which form a network between the terminations of the arteries and the beginnings of the veins. Carbohydrate. Any one of a group of chemical substances of which starch and sugar are the most familiar members. Carbonic acid gas. An animal waste product eliminated in the breath. In daylight plants absorb it energetically from the atmosphere through their leaves and decompose it, assimilating the carbon and returning the oxygen to the air. Cartilage. A firm elastic tissue, gristle. From this material many of the bones develop. Catheterize. To empty the bladder by means of a tube-like instrument which is introduced into the passage through which the urine normally leaves the bladder. Cell. One of the microscopical structural units which make up our bodies. Cell division. The process by which a single cell becomes 2 cells. Cerebrum. The portion of the brain which is the seat of mental activity. Chorionic membrane. the outermost of the two membranes which surround the embryo. Chromatin, a substance within the nucleus of a cell which has a special affinity for certain staining agents. Chromosomes, one of the pieces into which the chromatin is broken during the act of cell division. Clinical, pertaining to the sick bed. Colostrum, the fluid secreted by the breasts during pregnancy and for 2 or 3 days after the birth of the child. Contraction, the act by which the muscle fibers of the uterus become shorter and press upon its contents. Curettage, scraping out the lining of the uterus. Delivery, the birth of the child. Diagnosis, the determination of either normal or abnormal states of the body. Diaphragm, the muscular partition between the chest and the abdomen. Dietetic, pertaining to the diet. Duct, a tube which conveys the secretion from a gland. Embryo, the offspring before it has assumed the distinctive form and structure of the parent. Enema, a quantity of fluid injected into the rectum. Engagement, the entrance of the fetus into the birth canal. Ethnology, the science which deals with the character, customs, and institutions of races of men. Eugenics, the science which deals with the improvement of the human race by better breeding. Davenport. Excretion, waste substance thrown off from the body. Febrile, attended with fever. Fetus, the unborn child after the 3rd month of development. Foodstuff, anything used for the sustenance of man. Function, the discharge of its duty by any organ of the body. Gastric juice, the digestive fluid secreted by the wall of the stomach. Germinal cells, the structural units from which a new individual takes origin. The cell contributed by the mother is called an egg cell or ovum; that contributed by the father, a spermatozoon. Gestation, same as pregnancy. Gland, an organ which separates certain substances from the blood, and pours out a material, usually fluid, peculiar to itself. Hygiene, that department of medical knowledge which relates to the preservation of health, sanitary science. Inanition, the condition which results from insufficient nourishment. Infection, a disease due to bacteria. Intestine, the bowels, the long membranous tube extending from the stomach to the rectum. Involution, the process by which the uterus returns after childbirth to its former size and position. Lactation, the secretion of milk. Ligament, a band of tissue serving to bind one part of the body to another. Ligature, anything that serves for tying a blood vessel. Lochia, the discharge continuing for several weeks after the birth of a child. Lotion, any liquid holding in solution medicinal substances intended for application to the skin. Lunar month, a month of 28 days. Mammal, the highest order of animal, namely, one which suckles its young. Mammary, relating to the breast. Mastication, the act of chewing. Menopause, the permanent abolishment of the menstrual process, which generally occurs between the 45th and the 50th years. Microorganisms, bacteria and other living agents of disease which are visible only with the aid of the microscope. Miscarriage, the termination of pregnancy prior to the 7th month. Mucous membrane, the lining of certain cavities of the body, such as the mouth, stomach, intestine, uterus, etc. Mucus, the material manufactured by the glands in a mucous membrane. Muscle fibers, the muscle cells. Narcotics, drugs which produce sleep. Nitrogen, one of the chemical elements. Nucleus, a clearly defined area found in every cell which seems to be its seat of government. Obstetrics, the branch of medicine which deals with the treatment and care of women during pregnancy and childbirth. Ovary, the organ which contains the egg cells or ova. Oviducts, Two tubes, each of which leads from the neighborhood of one of the ovaries. Both terminate in the uterus. Ovum. An egg, the cell contributed by the mother to her offspring. Oxygen. One of the chemical elements. Pathology. The branch of medicine which deals with the altered structure and activity of diseased organs. Pepsin. A ferment found in the digestive juice secreted by the stomach. Pelvic floor. The muscles, ligaments, and other tissues which form the bottom of the basin enclosed between the hips. Pelvis. The bony ring formed chiefly by the hip bones. Posteriorly, the ring is completed by the sacrum. Perineum. The region extending backward from the outlet of the vagina to the rectum. It is the most essential part of the pelvic floor. Physiology. Scientific knowledge of the manner in which the various parts of the body perform their duties. Pigment. Any coloring matter. Placenta. The organ through which the communication between the mother and the offspring is established. One of its surfaces is attached to the wall of the uterus. At about the middle point of the other surface, the umbilical cord takes its origin. Prenatal. Pertaining to the period before birth. Protein. A foodstuff which is distinguished by the fact that it contains nitrogen and is a tissue builder. Protoplasm. The living substance in the cells which compose our bodies. Puberty. Sexual maturity in human beings. Pubic bones. The part of the pelvis which forms an arch in front of the bladder. Puerperium. The same as the lying-in period. Retina. The innermost coat of the eyeball, and the one which receives visual impressions. Rickets. A disease of infancy characterized by softening of the bones. Secretion. The product of the activity of a gland. Sediment. The material which settles to the bottom of any liquid. Spermatozoon. Plural, spermatozoa. The microscopic cell contributed by the male parent which stimulates the ovum to begin its development. Suppository. A medicinal substance made into the form of a cone to be introduced into the rectum. Term. The time of expected delivery. Therapeutic. Concerned with the treatment of disease. Thymus gland. A structure located behind the breastbone near the root of the neck. Only traces of it are found in adult life. Tissue. An aggregation of similar cells in a definite fabric, as muscle, nerve, gland, etc. Tubes. The oviducts. Umbilical cord. The structure carrying the blood vessels which pass between the placenta and the child's navel. Uterus. The womb, a hollow muscular organ designed to receive, protect, nourish, and expel the product of conception. Vagina. The canal through which the child passes from the uterus into the world. Vein. A vessel through which the blood flows back to the heart. Vernix. The fatty substance deposited over the skin of the newly born infant. Viable. Capable of living. Villi, singular villus. The microscopic finger-like processes which hang from one of the surfaces of the placenta and are surrounded by the mother's blood. Viscera. The internal organs which occupy the cavities of the chest and the abdomen. Vulva. The folds of tissue which surround the outlet of the vagina. End of the glossary. Read by Laurianne Walden. End of The Prospective Mother by J. Morris Slemons.